We welcome Dr. Venkat S. Ram to deliver his lecture, Hypertension, Newer Guidelines and Update. Sir is very senior physician cardiologist.
Good afternoon, ladies and gentlemen. Greetings to all of you. This talk, originally when Dr. Srinivas Kumar asked me to speak on guidelines, it was supposed to have been on JNC 8. That was the intention when he called me. Let me tell people who are interested in hypertension that there will not be a JNC 8. US government has decided that it will not be in the business of giving practice guidelines to medical profession. Medical profession should try to do it themselves. So the guidelines for hypertension from US now will come on behalf of ACC, American Heart and American Society of Hypertension. So the Joint National Committee concept has been removed abruptly with one simple statement from the director who is known to me, and he said that government should not be in the business of giving medical guidelines. So they're regulatory but not professional guidelines. So JNC 8 will not be there. It will be called Hypertension Guidelines 2013, may be ready by November or December, but there will be. The current guidelines we have are actually from European Society of Cardiology and European Society of Hypertension. Those are the latest guidelines published last month, and I'll give some features of it. The problem with these guidelines, you can actually download it from the website, European Society of Cardiology website. The problem with this document, I find it, is that it is 85 pages. And that is very problematic on a condition where you're giving guidelines for the treatment of hypertension. I had spoken with the chairman and I have suggested that we should have so-called express or a short version where people actually will read and comprehend. I'll be honest with you, very honest, I have not read all the 85 pages. I'll be very frank with you, but I have gotten some highlights. So let me present to you the highlights of the European Society of Cardiology and Hypertension guidelines. I have proposed to the World Heart Federation that there should not be any regional guidelines. European guidelines, American guidelines, British guidelines, what are all this? I have actually suggested that we should have global guidelines for the treatment of hypertension, and I have suggested to the current president of World Heart Federation, Dr. K. Srinath Reddy, that in the next 2 years, he and I should work on global guidelines so that we don't have to worry about JNCs and all this. Let us see what happens. Do we really need guidelines in 2013? The responses will be yes and no. The guidelines are required as guideposts. They will allow you to make some decisions. But on the other hand, they should not be used as an instrument of law. It is not a legal document. It is not illegal to do what is right for the patient, which could be a deviance from the guidelines. You must always try to do what is good for the patient, irrespective of the guidelines. And that is the reason why I sometimes wonder whether guidelines are needed at all when you have enough evidence from clinical trials and clinical judgment. But again, hopefully, if we have some global guidelines in the future, we should be able to do things much, much better. This is a document that was published recently, a very exhaustive document. So, ladies and gentlemen, for your convenience, I have made slides which are very abbreviated, which are very simple, and if it is okay with organizers like Srinivas Kumar or somebody here, I will leave it on the computer. As always, everybody knows any of my slides are open to be copied. No problem at all. This is what I have always followed in my life, and today is no different. Now, when you look at diabetes guidelines or lipid guidelines or hypertension guidelines, you will see this grading of various classes. Just remember, when you say grade 1, it is actually very good. Grade 3 means the evidence is not that good. But most of the evidence always falls in grade 2, which means the benefit-risk ratio. That is where you have to determine. When you have grade 1 evidence, you don't have to worry about it. Grade 3, you don't have to worry about it because you are not going to apply it. But grade 2A and B, where the risk-benefit will be seen, and this is something just keep in mind so that it's not complicated. Now, evidence-wise, when you say A evidence, that means it is derived from multiple randomized control trials. Placebo randomized control trials is very good evidence. On grade C, it is only consensus, opinion, editorial, or view. But most of the evidence is always level B, because that depends on a single large trial. Somebody might say UKPDS. That's a single trial, but that could be level B. It is good enough. Or somebody could say on target. Single large trial. It is not very robust, but it's good enough. So when you look at grades, all these things, remember that this is how they are staged. Let me go through very quickly. This is the classification of blood pressure from European Society Cardiology. It is no different than the previous classifications. In other words, number 1, there is no change in the classification of hypertension in the latest European guidelines. It is the same as 2003 and same as 2007. Now, this is what I have abbreviated so that you don't have to read that 85 pages of the document. They have identified a single blood pressure of 140 systolic. Any blood pressure that is greater than 140 is considered to be high risk, irrespective of the age. Whether you are 30 years of age, 40, 50, 80, so there is a single criterion of systolic blood pressure greater than 140. Because the reason is, people always ask me, what about hypertension in the elderly? Should it be 150 or 160? No. The risk starts at 140. So there is a single blood pressure they have identified is 140 over 90 or more. And in terms of the sodium consumption, again they have made it very simplified. About 5 grams of sodium diet is required to keep the blood pressure optimal as a non-pharmacological approach. Now, weight loss has once again been recommended. Very simple weight loss has been shown to reduce the systolic blood pressure, and aerobic exercise has been shown to reduce the systolic blood pressure by 7 millimeters of mercury. For uncomplicated hypertension, one should not combine ACE inhibitors and ARBs. In other words, patients who do not have diabetes, patients who do not have copious proteinuria, one should not combine ACE plus ARB in the treatment of hypertension. The biggest thing in these guidelines is a single blood pressure has been identified, 140, without mentioning it, a diastolic number. In other words, if we go back to our clinics after the meeting, you don't need a stethoscope to treat hypertension. That's what it is. Systolic blood pressure, if you palpate it, if it is more than 140, it identifies the risk and you do appropriate recommendation. I'm not downgrading diastolic, but the robust evidence is with systolic. The approach for drug treatment is also quite different. They have not recommended drug treatment for so-called high normal blood pressure, which was previously classified in JNC as pre-hypertension. Pre-hypertension was very complex, very confusing. Nobody knew what to do without it. So what they have done in these guidelines is so-called high normal blood pressure. Let us call it pre-hypertension. Drug treatment is not required. They made it very, very clear. Whereas in JNC 7, myself, I was included, we left it very ambiguous. That was a mistake. Now, there is a greater emphasis on home blood pressure and ambulatory blood pressure monitoring. This is a very major document that strongly recommends home blood pressure and ambulatory blood pressure monitoring. But they don't suggest that ambulatory blood pressure monitoring is superior to home blood pressure monitoring or vice versa. They should be used as complementary, where available. So one should not go into this argument, self-monitored blood pressure or ambulatory blood pressure. That argument is not there. Both of them are equally effective, but one should utilize these outside blood pressure to a greater extent if possible, depending on the situation. A very important statement. Now, they did not go into this hierarchy of various medicines. You select a drug that you feel is appropriate for the patient and you keep on adding the other drug. So they made it very, very simple. Now, for so-called grade 2 or 3 hypertension or JNC grade 1 and 2, you can simultaneously initiate drug treatment along with non-pharmacological treatment. This waiting for 3 to 6 months for non-pharmacological treatment, it sounds good when you read it, but it doesn't happen in the real world. Now, high-risk groups have been identified, which is again patients who have diabetes, patients who have cardiovascular disease, and patients who have chronic kidney disease. These are the high-risk groups. Chronic kidney disease is a major high-risk groups because the highest mortality that you see from hypertension is in patients who have chronic kidney disease. That is the reason why when you look at classification of chronic kidney disease from stages 1 to 5, you will never see many patients in stages 4 and 5. It does not mean we're doing a good job. It means patients are dying. They never have that opportunity to reach stage 4 or 5. They don't have that opportunity. They never reach 4 or 5. They die before. And that is the reason why this chronic kidney disease is a very important consideration, especially in our country. Based upon these major trials, they have suggested for elderly patients who are greater than 160, treatment is recommended. This is one trial that they have cited in the guidelines. They have suggested that in patients who have no diabetes or cardiovascular disease, when you treat them, you have a greatest reduction. And in women, there is a robust reduction in cardiovascular risk when you treat hypertension. Very important finding in the European Society guidelines. If somebody has a blood pressure greater than 140, it is important. But if it is greater than 150, then you should not wait. You should start the treatment immediately. And that is the reason why they have identified greatest benefit when the blood pressure is greater than 150, significant benefit if you are a woman, and a significant benefit if you don't have any pre-existing disease. That means this comes into the area of so-called primary prevention of cardiovascular disease by treatment of hypertension. Now, elderly patients are more and more now, people are living longer. So if you find somebody whose blood pressure systolic is greater than 160, there is no debate, there is no discussion, there is no difference of opinion, you have to treat them based upon the evidence, unless they have some life-limiting condition such as COPD requiring oxygen therapy or cancer or disability. If they're walking and talking, you should treat them very, very aggressively. Now, the threshold for so-called uncomplicated hypertension, the threshold should be less than 140/90. For patients who have chronic kidney disease, diabetes, the threshold should be in the proximity of 130/80. In other words, there is no benefit of reducing the blood pressure to 120/70 in diabetics. There is no benefit of reducing 110/60 in diabetics or CKD. If you reach the goal blood pressure of 130/80, that is good enough. Reducing the blood pressure further does not give incremental benefit. It's not dangerous. does not give incremental benefit. So actually the levels for treatment are a little bit high. I will not talk about end-stage renal disease. This is what very important part of the document, which I have already mentioned earlier, that there is a 1B evidence of treating systolic blood pressure to less than 140, but particularly in patients who have diabetes. Hypertension in the very elderly definition is somebody who's older than 80 years of age. If somebody is older than 80 years of age, that means he or she had a good life, right? I mean, if you become 80 and alive, you're doing fine. But if somebody takes your blood pressure, then what do you do with it? If somebody takes a blood pressure who is 90 years of age, who is happy, healthy, very, very good, walking, and happens to have blood pressure measured and it is 160, what do you do? Based upon the HIVET trial and European Society, these guidelines suggest, look at the evidence, there is fatal stroke by 40% and heart failure less than 64%. One should treat hypertension in the very elderly. But don't misapply this guideline to somebody who is unable to tolerate drugs, who lives alone, who cannot see, who cannot walk properly. You must always use clinical judgment. If somebody is 85 and is not in a good condition, be careful. But a healthy 80-85 only has blood pressure, it should be treated. Now, this is where it suggests that if you bring systolic blood pressure to 140 or less in people older than 65 years of age, there is tremendous benefit. You see here, if you bring systolic to 140 or less in older patients, you reduce the risk of stroke, all cardiovascular events, and surprisingly even mortality. You know, as you get older, it is very difficult to show benefit on mortality because, people die, you don't live forever. But on the other hand, in elderly hypertension, you can actually decrease mortality by treating hypertension, and it should be treated. Now, few things that we measure, please concentrate on this. There are some markers of vascular dysfunction, and the European Society of Guidelines comment on these markers because we get these tests. Left ventricular hypertrophy, the sensitivity is low, and to see any regression or reversal, it takes about 6 months or longer. But the prognostic value is very good. In other words, although it may not be very sensitive, but you cause regression of LVH, then that is very beneficial to the patient. And similarly, with urine protein, carotid wall thickness, intima media thickness, has received a very negative score in the new guidelines, saying that it has not been shown to have any prognostic value. So I think if you have to take 2 points from this, echocardiogram and grabbing urine for microalbuminuria are important markers, and they have prognostic significance. The major benefit of antihypertensive drug therapy is a fall in blood pressure, not its pharmacological action. And they are very bold in the new guidelines, saying that it is blood pressure per se that is the supreme controller of cardiovascular events, whereas the pharmacological property could have some ancillary benefits. So if you look at totality, they are suggesting medication per se may not be important, but the blood pressure is important. But you have to use, diabetic patients, you use ACEs and ARBs, and post-MI hypertension, you use beta blockers. Those kinds of things are still there. The true 2 drug combinations, and now in India we have 3 drug combinations also. There are some benefits to it. The only problem would be that if somebody develops side effects or adverse effects on double drug or triple drug combination, it is sometimes very difficult to discern which component of combination is contributing to it. Difficult to discern, not impossible, difficult to discern. So it is advantageous, but it is difficult to separate the side effects. Now, one combination that is in the red color is strongly discouraged in the European guidelines, and I would endorse it, the combination of ACE inhibitors and ARBs. So you will notice that all other combinations are quite appropriate, but ACE plus ARB in uncomplicated hypertension is not contraindicated, but it's not desirable. White coat hypertension, which is very commonly discussed in meetings, office hypertension, or whatever you want to call it, there is no evidence that drug treatment of white coat hypertension prevents the onset of fixed hypertension. There is no evidence that drug treatment of white coat hypertension prevents vascular disease. So, when somebody has so-called white coat hypertension, you have to delineate further by getting home blood pressure or ambulatory blood pressure and then treat accordingly. That's same as before. Diabetes mellitus, I think it may have been discussed before by Dr. Sahay and others, I do not know. But based upon the ACCORD trial, they suggest the treatment goals will be same as before, but not super aggressive treatment of hypertension in diabetics. So one should treat the way you are treating, but not too rigorously. Actually, none of them really go to very low levels anyway. So you treat to target as much as needed. Resistant hypertension, they made a statement that in patients who qualify for the definition of resistant hypertension, there is class 2B evidence that renal denervation therapy or baroreceptor activation therapy may be useful in these patients. Again, if you look at the last 2 points which I have highlighted in the color, that will be the take-home messages for renal denervation therapy for resistant hypertension. It is very promising, and Dr. Srinivas Kumar is going to discuss it very soon. And it is very promising. I even would concede that it could be useful also, but we need to look at the outcome data in the future, and you need to see if cardiovascular events and renal events can be reduced as a result of a mechanical treatment of hypertension. That has to be seen. Now, I will conclude, Mr. Chairman, very soon. This is a very complicated slide. Most of they go through this color profile. I'm only showing it so that I can tell you. If the patient has significant hypertension more than 180 or 110, don't worry about anything. You just have to treat them. But if it is under 180, under 160, between 140 and 160, then you take into consideration other risk factors the patient has. If the patient has multiple risk factors, then even high normal blood pressure should be treated. You will notice here that you have to treat high normal blood pressure also in patients who have multiple risk factors. But as the blood pressure increases, the need for multiple risk factors as an indication therapy decreases. But as the blood pressure threshold goes down, then you have to see whether the patient has diabetes, CKD, family history, obstructive sleep apnea, high BMI, those. But high levels of blood pressure, none of these count. So it is that borderline cases where you have to see what is the cluster of the risk factors that the patient is taking, has, so that you can intervene. So ladies and gentlemen, in the time that was given to me, I have provided to you an encapsulated synthesis of major observations and major findings and recommendations from the European Society of Cardiology guidelines. And let me summarize. They have identified a single blood pressure to distinguish between risk and benefit, namely systolic blood pressure of 140. They did not give any preference to a hierarchy of a drug class because blood pressure reduction per se is useful, but they have suggested that adjunctive properties of the drugs should be taken advantage of in people who have so-called comorbid conditions, which you already do. They have not identified that elderly patients should have a higher blood pressure to be treated. It is still the systolic blood pressure 140, same. Actually, even for children, they have recommended it should be 140, but with one caveat, because there are no outcomes data in children, which you will never have. So the only thing that pediatricians do, they have a table that is published. Actually, it's published even in pediatrics journals in India, that you go by the percentile. If somebody has a blood pressure that is above 90th percentile, that means if you don't belong to 90 out of 100 children, you have to be treated. This is what has to be done, and they have tables for that. So even for children, for youth, for adults, for elderly, they have identified a single level of blood pressure in European Society of Cardiology. And they have also suggested the combinations, the favorable combinations, and the combinations that are not useful. They have commented on renal denervation. They have emphasized the importance of gender as a high-risk group, etc. So the take-home message would be really to apply what are the trials that have become available from 2007 till now, and apply them to the best benefit of the patient. So there is no mention about the use of direct renin inhibitors in the treatment of hypertension due to lack of outcome studies and due to a negative study called Altitude. And apart from this, let me mention a couple of things and then I will conclude. That with certain angiotensin receptor blockers, there are some reports of sprue-like symptoms with olmesartan, enteropathy-like symptoms with olmesartan, and this will be followed in the future, whether this is drug-induced or does it have any significance at all. And I mentioned to you earlier in the diabetic session the recent study that short-acting CCBs are associated with higher incidence of cancer. We don't have to worry about it. I gave you the explanation why people have higher incidence of cancer when you live longer. And moreover, nobody uses short-acting CCBs anymore. I don't think so. And there's no reason to use them. And there is a big compendium on workup of secondary causes of hypertension. But a session like this will not allow me and you to have a justified discussion on workup for secondary causes of hypertension. With those remarks, I'll conclude, Mr. Chairman. Ladies and gentlemen, thank you.
Thank you, Professor, for nice lecture on the hypertension. I would just ask about diastolic hypertension. What is your impression about diastolic?
Yeah. Actually, the diastolic hypertension remains as an important factor because it represents an increase in systemic vascular resistance. But the one that appears to have a greater predictability of cardiovascular prognosis is systolic blood pressure. So let us say you have somebody who has got 130 or 96, 120 or 95. The risk is there. The risk is there. So here what they have done in these guidelines is they feel that usually both are high, unless in the elderly group, and there is no reason to demarcate into two separate targets for treatment. A single target is good enough even to reach diastolic. And one more thing that I find it a little bit surprising when I was reading is instead of using target organ damage, TOD, that all of us are used to, they just used OD. And I thought maybe in copying or something the T got mixed up, I kept on reading it. They removed T in the guidelines. They just use organ damage. I don't know why, but when you see OD, don't get into confusion that you are missing something It is nothing but previous TOD.
What are the recommendations for pregnancy-induced hypertension as far as level and newer drugs that are allowed?
No, nothing changes in pregnancy other than pathophysiology. A lot of interest on pathophysiology, which we discussed it in the forums here. A lot of new data on pathophysiology, very, very interesting data that will lead to treatment in the future. Now, for so-called pregnancy-induced hypertension, or let us call it preeclampsia, that is better term. If the blood pressure is greater than 150 over 100 millimeters of mercury, there is evidence that lowering the blood pressure is helpful for the mother. So if you see somebody has a preeclampsia, by classical definition, 150 over 100 should be treated with the usual modalities that we have. Bed rest, which is useless, absolutely useless in my opinion. You can never have anybody have a bed rest unless you're not able to walk. So that is different. So, but they do recommend bed rest. And the drug that can be used would be methyl-dopa, followed by hydralazine, followed by labetalol. These are the drugs that should be used if the blood pressure is greater than 150 or 100. The idea would be to prolong the gestation to at least 34th week, if possible. 36 is preferable, around 33, 34, I think the maturity is good enough for delivery. So there's nothing new in terms of the treatment. There's a lot of new about pathophysiology, but pathophysiology is never discussed in guidelines.
Sir, I have got something. See, it is related to the hypertension with the elderly people. See, it is a very well-known fact that your indirect cuff measurement of the blood pressure is a problem with the elderly people. So, chances of the pseudo-hypertension recording is 1. So, what's the recommendation? How to record? This is one point. Second point is that quite often it has been seen and witnessed by all of us that the elderly people, your pressure is quite high when they are supine. The moment they stand up, the pressure goes below the limit where you want to initiate a treatment, the so-called postural hypertension. Now, what the guidelines is, shall we take the baseline sleeping position as the marker to start the treatment, or we shall not treat?
Okay, the first question is arterial calcinosis, or you call it pseudo-hypertension. Some people call it lack of elasticity. It's all the same thing. There is no clinical way of distinguishing between pseudo-hypertension and real hypertension unless one does an unusual procedure, which nobody would recommend, is to check intra-arterial blood pressure. That we will never do it. But on the other hand, if you have somebody who has significant hypertension, elderly, who has paucity of organ damage, no LVH, no retinopathy, creatinine 0.8, and you listen to their neck, no bruise, nothing, then that could be pseudo-hypertension. So that's where the clinical judgment comes. And there is no other way of determining. I can't say of any way of distinguishing between pseudo-hypertension, resistant hypertension, and real hypertension. Now, the guidelines for treatment of systolic hypertension, they're all based on sitting blood pressure. They are not based on standing blood pressure, postural blood pressure. But if somebody has a postural drop that interferes with their ability to have a normal life, so-called activities of daily living, then you should always be very careful not to reduce it any further. And no guidelines will actually say ABC because there's no evidence. Because guidelines are all evidence-based, it all becomes clinical judgment. So if I'm treating an elderly patient and the patient really has the degree of postural hypotension that doesn't permit continued antihypertensive therapy, you can back off. Then you can say, Dr. Ram, the patient is at high risk of stroke. That is correct also. So sometimes all these questions have several correct answers, and you choose one that you feel is appropriate. That's what I'm saying. It can happen. One more phenomenon I want to mention about the elderly, very common, is postprandial hypotension. Elderly patients have higher incidence of postprandial hypotension because they have tremendous pooling of the blood in the splanchnic blood vessels after the distension of the stomach. This is well known in physiology. The distension of the stomach causes splanchnic vasodilation, and basically it is pooling of the blood in the splanchnic area. So postprandial hypotension is very common in the elderly. If somebody complains to you that he or she is feeling giddy after a meal, they're not bluffing. It's real. And then you adjust your antihypertensive medicines accordingly so that it is further away from the consumption of the meal.
Regarding gestational hypertension again, there are some reports, and the gynecologists, they do follow the prophylactic use of aspirin as a preventive. Any comment on that?
Oh, definitely. Prevention of, let us call it preeclampsia. Number one, low sodium diet does not work. Number two, diuretics do not work, they aggravate the risk. Number three, calcium could work in patients who are clinically calcium deficient. Then 2 grams of calcium has been shown to help. Aspirin is the only drug that has been shown to have a prophylactic effect of reducing the conversion of preeclampsia to eclampsia by 30%. So if somebody is at high risk for preeclampsia, because I'm only talking about preeclampsia, not chronic hypertension in pregnancy or gestational hypertension. So typical preeclampsia, if somebody is at high risk, multiple babies, diabetes, family history, previous history of preeclampsia, the typical features, then aspirin has been shown to be beneficial, 30% reduction from converting to eclampsia. So that is the only preventive approach that has been shown to be of some benefit.
Your comment on cilindipine and nebivolol, your drugs.
Okay. So, I will, but I don't know about the time because our chairman Srinivas Kumar is in the audience. So he has to. Okay, cilindipine. I'll very quickly. Cilindipine, because of the dual acting nature, both L and N channels being blocked, blocks calcium flux and blocks the neuroeffector hormone action at the blood vessel. So it is a superior pharmacological agent compared to amlodipine. Appears not to cause ankle edema, and this is the only dihydropyridine that I know of that behaves like an ACE inhibitor in the kidney and behaves like a beta blocker in the heart. It reduces proteinuria and it reduces the heart rate. So cilindipine is a calcium channel blocking drug that works on blood pressure as a CCB, works on the kidney as a ROS blocker, works on the heart as a beta blocker. So pharmacologically, it is a good compound pharmacologically. No outcome studies. Only outcome studies or intermediate points like LVH and proteinuria. And the cardiologists use that systolic time minus diastolic time divided by ejection time. They call the TI index. That right? That's a global function irrespective of the heart rate. So usually when you look at the heart function, it correlates, heart rate is a factor. But when you remove heart rate, that's where the cardiac function is. That has been shown to get better with cilindipine. And there are comparative studies, amlodipine increasing proteinuria, etc. Now nebivolol. There is a mention in the European Society of Guidelines also that vasodilating beta blockers from a pharmacological point of view are beneficial compared to non-vasodilating beta blockers. Nebivolol is a vasodilating beta blocker like celiprolol, carvedilol, etc. Because it causes vasodilation in microcirculation in the pancreas and in the liver, it causes greater insulin delivery.